Hello, this is Ken Kinter. I'm an assistant professor at Rutgers University, and this is a video on 3 steps to safety. The purpose of that is to help with training purposes. It's the second in a series. My contact information is on the first of the series, which is called Trauma-Informed Care, and should accompany this. So 3 steps to safety basically is a way to try to reduce the possibility and risk of violence. So in order to set the stage for this, let's talk about the type of violence we see in inpatient facilities. And it tends to be of 3 types. Instrumental violence is purposeful violence, violence with a plan. An example that I've seen is where before a patient gets discharged, they may do a home visit. Some of the people on the unit may say, hey, bring me back some cigarettes, bring me back some alcohol, bring me back something, and if you don't, bad things are going to happen to you. I've also seen the example where patients dictate to staff what their treatment is going to look like or what kind of medications they want. If you don't give me Xanax, I'm going to flip over a table, et cetera, et cetera. So, but it's a plan. People know they're using violence to achieve a specific goal. Second example, psychotic violence. This is violence that comes right out of the psychotic processing. People feel like you may be a demon, that you're attacking them, that you're trying to kill them, people that are particularly paranoid. So it comes right out of the symptoms. The third is reactive violence. Reactive violence, I would almost call it impulsive violence. Something bad happens immediately with someone and it results in violence. Think about violence that happens after contact with family, or contact with just some sort of conflict with someone, and then it spills over. So of these types of violence, the one we see most often is reactive. So more violence comes to as a result of poor impulse control than, say, purpose or psychotic symptoms. And as you can see here, the medication actually has a good influence on the psychotic symptoms. A little harder to medicate intent, behind the instrumental violence. And then you see the difference in reactive. It's interesting to notice here between forensic and civil hospitals, you see the uptick in purposeful instrumental violence in forensic facilities, and it decreases a bit in the civil. So that's kind of interesting in terms of, the criminality of violent behavior versus just really poor decision-making or poor coping skills. It also speaks to how important it is that we work on coping skills while people are in the hospital, since, that's one of the main contributors of violence. So I jokingly refer to this part of the training as how not to get your butt kicked. The first step in how not to get your butt kicked is, first of all, know your clients. Know them. Know what sets them off. Know what settles them back down again. 2, have a good relationship with your clients. If the first time you're talking to them is when a crisis is going on, you've missed an opportunity to keep yourself safe and to keep them safe as well. They should have a good relationship with you, a respectful relationship with you, where you say hi to them, you express concern for their well-being, you help them out. If there's something that you can do to help make their day better, their stay better, then you do it. Because what's happening is all while you're doing that, you're contributing to what we refer to as a bank account. The better you know someone, the stronger your relationship is with them, the bigger that bank account is. There are people in your life that can tell you anything, and you will listen to what they have to say, even if you don't agree with it, because of who they are, because of the strength of that relationship with you. I don't have that relationship with you, so I can't necessarily say that. You won't hear that coming from me. And with patients, it works the same way. Someone they like, trust, and respect, have a good relationship with, they are less likely to be violent toward. And they're more likely to be violent to someone they don't know, someone they have an adversarial relationship with, or someone that they feel is trying to control them. So, number 3, know when you are moving into a hot zone. And I affectionately refer to a hot zone as any scenario that may increase the risk of violence. If you're in a confined space with someone, that's a hot zone. If you are in any of those scenarios that we just talked about before, where you're catching up with someone just after they've gotten bad news, or when they're particularly psychotic, or if they're trying to get away with something, that's a hot zone. Here's another example of a hot zone. These 3 scenarios here. 1 is limit setting. If somebody's doing something and you're telling them to stop, they have a choice to whether they're going to comply with that request or whether they're going to be violent. Number 2, activity demands. You're telling somebody to do something, get out of bed, take medication, go to group. There's the possibility that they may say no and react violently. Number 3, denial of requests. Person asks for something, your answer to them is no, whether it's reasonable or unreasonable. But that no can very often be met with violence. When you're in one of these 3 scenarios, you're having this interaction with someone, they're checking the balance in that checking account. And if your check bounces, violence can be part of the result. And it's our problem if we did not do our due diligence and form that relationship, that respectful relationship with somebody first. Another point on this slide is these can be made worse by perceived procedural injustice. Big fancy term. All that means is the phenomenon where things don't always run in the hospital the same way. Things run a certain way on day shift and they run differently on evening shift and on night shift. They may run differently Monday through Friday than they do on a weekend or on a holiday. They may run differently when there's one person in charge as opposed to another person in charge. But what happens is a person feels that they're being treated unfairly. If they could do something Tuesday but can't do it Wednesday, if person A is allowed to do something and person B isn't, then that leads to a person feel like they're being singled out. And one of the things you really want to look out for is you don't want a situation to become personalized. You don't want that person to say, oh, well, you're telling me I can't do something. That will go poorly. And as soon as a person personalizes it, they just increase the possibility of violence taking place. So here are the 3 steps to safety. Now, there's a few more pieces to it than just what's right here, but the 3 essential pieces are validate, explain, and problem solve. Now, I'm hoping in the handouts that you have accompanying this, you have a 3 steps to safety score sheet, and we can use that to go off of this. And I'll be referencing that while I'm explaining the steps. So before we even get to validate, before you intervene in a situation, assuming that you have time to do so, take a breath. Take 1 breath. If you have 3 or 5 seconds to spare before an incident happens, take a breath. It will help you not bring anything that you've got going on already to the current situation, and it will give you more time to think about what you're about to say or do. Many bad things have been prevented by a well-timed taking of a deep breath. It's something that I use to help de-escalate people. Just the idea of being able to stop something for a moment long enough to take a breath is as important as the breath itself. So once that breath is completed, and this one is probably the one that we do the worst, validate. All validate means is that you are showing the person that you understand where they're coming from. Behind every patient request, there's something that makes sense, whether they can have it or not. If they want to use the phone at 3 a.m, well, maybe they miss their family. They're in a hospital. You can get that. If they want food in the middle of the night, well, okay, maybe you can't have food in the middle of the night, but haven't we all raided the fridge at 3 a.m. or one time or another? Right, it's just me. Yeah, sure, just me. This is just an attempt to be human with the person. Before we go into the rules and how it has to be and what we're going to do, we're just basically acknowledging, I get that you're upset. I get that you're angry. I would feel the same way. If I were in your situation, I'd probably feel the exact same way. Something along those lines. We're acknowledging the humanity of the situation before we move on again. Because we're people before we're MSOs and HS staff and social workers, right? We're people first. And it's important to relate to people on a human level, especially when they're upset. Someone's in their emotional mind. They're not really thinking that clearly. So after validation, explanation. The explanation is the why. Why is this request being denied? Why are you asking this person to do this? And this should be tied very closely to hospital policy. And it helps if you say, well, this is how we treat everybody. It's the same rules. And we know those rules aren't always universally applied the same way. This isn't personal. We don't have enough escorts. This is hospital policy. I didn't make this up. And I get that you're not happy about it. But these are the rules. Some version of that. We usually have the mistake when we lead with this first. You do the humanity part first and then bring the rule. That's an important point. So we validated their emotions. We've explained what the rules are. Now we get into problem solving. What are we going to do about this? Now, obviously, at some point down the line, violence or dangerous behavior has been an alternative that people have used. So we can say, okay, well, this is what you would normally do. When you get angry about something, you get upset about something, this is what you normally do, and this is where it leads. What other options, what other alternatives do we have? You can flip over a table, you can wreck something, you can hit somebody, you could do that. I don't think it's a great idea, and this is where it's going to lead. This is why I don't think it's a good idea. What else can we do? What other options do we have? And there's a very old trick of the trade that I'll take the example of, okay, you're driving to work and somebody cuts you off and almost gets you in an accident. Now, usually your first thought isn't the nicest thought in the world. You might think about giving them the finger. You might think about driving up to them and giving them a piece of your mind. You might even have thoughts that are even more, say, extreme than that. So that thought happens. Then the second thought is, I can't do that. Like, not going to give this guy the finger. I'm not going to run him off the road. You imagine me getting in a fight with somebody over some motor vehicle thing on the way to work? Silly. But then how do you acknowledge how you feel? Because your heart's thumping in your chest, your adrenaline's going. So to not do anything doesn't sound like such a great plan either. So is there a third? What's a third option? In that scenario, my third option is I'm going to drive a little slower. I'm going to take some breaths, get myself back together again. Might change what kind of music I'm listening to, might listen to something, try to relax me a little bit. I'm going to be a little more careful, a little more mindful about what I'm doing, and take a little better care of myself. So I would ask you, when we're doing problem solving with the clients, can we come up with 1, 2, 3 alternatives, particularly if one of those alternatives comes out to be violent in nature? So how do we deal with being upset? How can we get you what you want? So in the example of a person wants to use the phone at 3 a.m, we say, we can't use the phone at 3 a.m, but what can we do? We can make sure that you can get a phone call in first thing when we can do it. I can't get you food now, but I can't get you a meal tray now, but food may be coming at breakfast time. Maybe there's something, crackers or a juice or something like that. What are the options that are available? And again, I want to have 3 different options. The last part of this is, what can you do to help? So again, with violence comes about when the patient sees you as an adversary. There's you, there's them, and then there's violence in between. What we want to do is get on the side of the patient and help them to succeed. So what can we do to help? Okay, you can't use the phone now, but I'll make sure I'll reach out to the social worker, make sure they know about it. So when they come in, they know that you wanted to use the phone. I'll make sure that, I will make myself part of the solution. Whatever little thing I can do, I will do. The last thing somebody wants to hear is, that's not my job, end of story. If it's not your job, and whatever it is may not be, but what can you do? You can reach out to the person whose job it is. You can follow up on it. And actually following up is a very interesting point as well, because you might want to check back in with that person later on and see how they're doing. One of the best ways to reduce crises and do crisis prevention is by checking back in with that person and saying, you had a really tough morning this morning. I just wanted to see if you're doing better. Wanted to see if that phone call worked out, whatever that is. You get a chance to be part of the healing process, as well as, the process right where that intervention happens. Now, hopefully what happens now is there's a video that has a few vignettes that the good people at TPH made for us. And you can use this score sheet to evaluate how they did as far as their validation, their explanation, their problem-solving skills. You may have also noticed on the sheet that there's a piece about nonverbal communication. So what was the tone of voice like? What was the interpersonal distance like? Was anybody cornered? What were the nonverbal things that were either done well or poorly? So the person who's actually doing this training can show you those videos, and you can critique them on the form. But I also want you to be thinking about how you appear. Do you get up close to people? Do you square off with people? Do you have your hands up on people when you're talking to them? What are your nonverbal communications like? Because sometimes the nonverbal communication is actually more of an effective form of communication than the verbal is. And the name of the game is about keeping you safe and keeping the clients safe. All right, so this concludes the second part of this three-part training. Again, there are reference materials that are going to be at the end of the third segment of this, which is going to be motivational interviewing and OARS. And my contact information is on the first slide of the first section, which was trauma-informed care.